Well, welcome everybody to our grand rounds. I have a distinct pleasure of, you're in here for a treat. My friend Jack Singh, a mentor from FAR, is here, and I'm really excited about the conversations we're going to have during his talk. Dr. Jack Singh is a professor of medicine at Harvard Medical School. He's a former clinical director of cardiology division and the Roman De Sanctis Endowed Chair in Cardiology at Mass General Hospital. He's also the founding director of Resynchronization and Advanced Cardiac Therapeutics program at Mass General Hospital. He completed his internal medicine residency and cardiology electrophysiology fellowships at Mass General Hospital. He completed his doctorate from Oxford University, a Master of Science in Clinical Investigation from MIT Harvard, and a research fellowship at Framingham Heart Study. He has over 350 peer-reviewed publications, and they're growing by day. He's given over 475 invited lectures at national and international conferences, and he's the former deputy editor of the Journal of American College of Cardiology and editor-in-chief of the current treatment options in cardiovascular medicine. He's a national and global principal investigators on 7 ongoing multi-center clinical trials in device therapy, sensor strategies, and AI for heart failure and atrial fibrillation. And much of his current efforts are focused on healthcare redesign, digital health, and medical device innovations. And he's the author of a best-selling book called Future Care, Sensors, Artificial Intelligence, and Reinvention of Medicine. And we're pleased to have him at University of Michigan to talk to us about his book. Thank you.
Thank you, Hamid. Thank you for the invitation. I want to thank the entire department and Kim Eagle and Tony Rosenzweig all for being here and inviting me. It's been a phenomenal morning today, and I kind of feel unworthy in giving this talk to all of you guys. We're doing so much of innovation out here. But I'm excited at the same time to talk a little bit about something beyond being an electrophysiologist. That's really talking about the breadth of cardiovascular care. Before I commence, these are my conflicts. I do not feel that any of them will impact my talk or the content of my talk in any particular way. So I'm going to start with this saying that many of you may have heard from Alvin Toffler, who's a great American writer and an American futurist, who said that change is not merely necessary to life, it is life. I think this might resonate with probably everyone out here because all of us have seen a lot of change, whether that change is socially, culturally, geopolitically. And medicine too is changing. Medicine is in this state of transition. It is in the state of transition in the way we will actually receive and deliver care in the near future. And with that, my objectives today are largely to really talk about some of the gaps in our healthcare system, talk about how sensors, data, and AI can actually fill some of those gaps, and then go on to really elaborate on how some of the future models of care might look with AI and sensor-based strategies and how we need to kind of adapt and flex to accommodate those. Now, before I commence, I thought I'd give a little bit of more of a history into my personal life to tell you where I started, because it gives you an idea of my vantage point. Right on the top on the right is where I trained. I trained at in BJ Medical College in Pune in India. I grew up in India, did my med school in India. That's a classic ward. It's still the ward. They have about 30 cots in one big ward, and they have 30 beds on the floor and 30 on top with family members around. That's a spruced up version, but that's where we delivered care. I subsequently went to King Edward Memorial Hospital in Bombay and did my early part of my cardiology, where I think I really developed my backbone. And subsequently to that, went on a scholarship to Oxford, did my doctorate there, landed up in the US at the Framingham Heart Study, did some cardiovascular epidemiology there, and then got my foot in the door at Mass General Hospital. Did my internal medicine, my cardiology, my cardiac electrophysiology, all at MGH, and I've been there now for 25 years. And so far, I've managed to escape the wrath of the administration, and I haven't been fired. So It's been a great journey, but the reason for really telling this to you is that I too have seen some change. I have worked in what would be an under-resourced part of India. I have worked in a resource-constrained environment in the UK. And I worked in a really well-resourced environment in the US. But unfortunately, none of them work really well. And focusing more on the US system today, I think you'll all agree with me when we use the phrase that it's big, fat, and sick. And I say that because 1/5 of our GDP, which is almost $20 trillion, 17 to be exact, are spent in healthcare. And despite that, we are indefensible when we look at quality of care metrics. We're indefensible on the millions of uninsured. We're indefensible on long-term mortality statistics and infant mortality statistics. And I think that arises because of many things, not only the fact that we're probably inept, maybe ineffective to some extent, and inequitable in a big way, which I think all of us saw during the COVID years. But I think we're very opaque. We talked about this morning during the discussion at the round table that, we are very opaque in our reimbursement systems. We are very non-transparent in the variability in practice between hospitals within practices itself, leave alone between regional, national, and international practices. There's so much of variability and there's so much of opaqueness that it becomes challenging to really change the system as a consequence of that. But beyond that, I think it's really important that we seem to talk out of both sides of our mouth. We talk about value-based care, but we are beholden to a culture of margins. I think everybody will agree with that. And beyond that, I think most importantly, the wellness of our institutions, the wellness of our organizations is dependent on the sickness of our patients. And until we don't flip that argument across, I think that's going to be the big problem that we're going to continue to have with medicine the way it's practiced at this point in time. Now, we're talking about cardiovascular care. I know we're a variety of phenotypes here in the room, and if there's a webinar out there too. So I'm going to not talk too much of electrophysiology, but try to keep it in very general terms. But I think when you look at the risk of heart disease, it is the biggest killer right now in the United States for sure. And the contributors to heart disease in the US are many. But the main thing is ischemic heart disease, hypertensive heart disease, ischemic strokes. Those are all the vascular contributing agents out here. But if you look further down at the metabolic risks that really cause heart disease, there are high systolic blood pressure, high BMI, diabetes, hypercholesterolemia, and kidney dysfunction. Common things that we see in clinical practice are the bigger contributors to heart disease. And let me tell you where I'm going with this. I'll tell you this. He had a wider Q. The FDA, many, and he was recently colleagues that his one was not a person that has to do. I synchronization therapy, but before actually happened, what went wrong with Paul is that and grass result there also count out by. So it was not trying a little back percent to 30%, and I'll start a little bit. Talk more about, I went ahead. So the main story in medicine is not about establishing a diagnosis. It is for the patient, a completely different perspective about really finding a tenable life with disease. How do you deal with heart failure, and how do you deal with kidney failure and go for a dialysis on a daily basis? That's the story of their life, and that's what takes them up completely. On the flip side, for a clinician, it's about bridging the gap between patient expectations on a daily basis in a busy working hospital environment, and God only knows we fail at that multiple times on a daily basis because of the lack of time and the inefficiency within the system. But now things are getting a little different. They're getting different because we are blessed with data. We are blessed with unlimited connectivity and massive processing power that can potentially change the way we receive and deliver care. And if I can leave you with one message, and I think most of you already know this, is that the future of care will be virtual, at least partially virtual. It will be sensor-aided. It will be powered by artificial intelligence, will necessarily need to have sustainable workflows that translate into clinical outcomes. Okay, a lot of parts to this equation, but it's a simple equation, and we already have all the different parts of this equation ready. It's a question of actually bringing them together as these different parts get more sophisticated and keep getting advanced. So let's break this down a little bit. Now, when we talk about sensors, I think it's important to recognize that the word sensor comes from the word senses. And there's a lovely saying by Immanuel Kant who says that all knowledge begins with the senses. So the senses, that is our ear, eyes, nose, vision, all these senses that come into our GPU, or graphic processing unit up here, is what gives us intelligence. And it's interesting, which many of us don't realize on a daily basis, that every analog experience, whether it's touch, sight, smell, whatever it is actually an electrical experience. Every experience, every cell operates through binary codes. Every one of these experiences can be broken down into binary codes. And this brings up the fact that we are now in a situation where we can potentially digitize the human body, create digital dashboards, which are like automobile equivalents with a check engine light, so that we can predict and prevent, as well as forecast disease and proactively intervene as and when this may occur. So I think it's important to recognize that these sensors can actually help us get there. But the fact of the matter is that we've been doing this for a while. We've been implanting sensors in hearts for a few decades, if at all. These sensors within, for example, the implantable devices that we implant, that Hamid implants, that our pacemakers and defibrillators and resynchronization devices, they have the ability to measure heart rate, accelerometers, physical activity, transthoracic impedance, can measure the fluid in the lungs, can measure the respiratory rate. They can measure even the heart sounds now. And besides that, there are a slew of sophisticated sensors that I'm not going to get into, but can measure pulmonary artery pressure, left atrial pressure, and even some sophisticated metabolites that can help us understand the physiology of the patient a lot better than where we are. Now, not all of these are fully implantable devices that need to be connected to the heart with electrical wires, but there could be self-standing alone electrical devices like the implantable loop recorder, which has all the same measurement strategies that we just talked about. You can have sensors that are implanted in the interatrial septum. You have sensors that are implanted into the pulmonary arteries. You have sensors that can be implanted selectively into left atrium, which can actually measure pressure. And this is some early work we did out here, where you could actually measure the left atrial pressure, and the patient at that point in time could hold a Palm Pilot-like device and read out his left atrial pressure and adjust his diuretic dose based on what the left atrial pressure reading is, right? That study obviously was failed for a variety of reasons, and we can talk about that. But the idea of self-management strategies using sensor-derived data is not a new one, okay? And now these implantable sensors, we've been implanting them for a while, and we can actually distinguish which patients are going to die within 1 year by 4% if they have a risk score that is 1, and if they have a risk score that's 4, there's a 20% mortality. There are sensors that can now help us actually predict which patients are going to develop heart failure hospitalizations. And there are sensors now that automatically can measure cardiac contractility from a sensor inside the right atrium lead and adjust the pacing parameters of the device to accommodate and individualize the therapy as it's delivered to that particular patient. And beyond that, we then have sensors that measure heart rate, heart sounds, respiratory rate. And we found that creating an integrated sensor blended strategy where you're not led by false positives from single sensors allows us to actually determine which patients are going to develop heart failure 30 days before they actually develop heart failure. And this is just a multi-sense study. And now you have the Selene-HF study and the Triage CRT study, which actually do exactly the same thing, predicting which patients might actually go in to develop heart failure 30 days before they actually do. And remember, Paul had heart failure, okay? Now, not all patients have implantable devices, and not everybody wants to get an implantable devices, but there are now a slew of wearable devices that can be used to really digitize the entire human body. These devices can be worn on, wrists, watches, they can be worn on your glasses, they can be earbuds, they can be worn on cufflinks, they can be clipped on the shoe. There are sensors now that are tattooed into the skin. They're already being investigated that can change color depending on your blood glucose level, change color depending on your oxygen saturation. So there are other ways, and these are temporary sensors that can be tattooed on and they disappear after 2 weeks. So there's stuff that is going on out here, and there's sensors obviously on the toilet seat that can measure your weight, record your ECG, even measure your blood pressure, and then at the end of it also assess your microbiome. So there are different ways that these sensors are finding their way into clinical practice right now. But the big thing is, how do we get it all together? And this is where the smartphone kind of begins to play a bit of a role out here, because to get all this information from all these sensors, there has to be some sort of mothership out there. And that's where the smartphone allows us to provide high-touch technology. It's almost like concierge medicine. Concierge medicine is where you're constantly interacting with your clinician. A smartphone has the ability now to have all the clinical tools within it, has the ability to have and receive all these sensor-based approaches into them. And they can now, there are apps and smartphone strategies to monitor patients with hypertension, with diabetes, with heart failure, all of the 3 things that Paul had. Okay, I'm going to circle back to Paul later on. But the important thing out here is that Paul started actually feeling better. His ejection fraction now from 25% went up to 45%. Still very brittle, still had repeated hospitalizations, was still on hemodialysis, also had atrial fibrillation. And we know when atrial fibrillation occurs with heart failure, it's a double whammy. Patients don't do that well. And he also had ventricular tachycardia, which non-sustained, and then some short runs of paroxysmal VT also at the same time. The important thing was that in 2006 now, we still didn't have sensor strategies. They were just about being developed, built into these devices, and we're not there at the time to monitor Paul from a distance. So around COVID time, I'm going to shift gears out here. Just go back, visit the virtual component so that we can come back to the sensor component in 2 seconds. But one of the things we did around COVID was we quickly did a study in about 5,000 patients to see how we were delivering telehealth. And we found, as you can well imagine, that there was a large subset of patients who did not get telehealth appropriately delivered. Video visits were not possible. And a large proportion of those patients, you can understand, were disenfranchised. There were Black patients, Hispanic ethnicity, elderly patients with a low household income. But the point I really want to make out here in addition to this was that there were a large number of them were heart failure patients. And that's because there's a fair amount of collinearity between all these other variables with patients with heart failure, right? What we did at that point in time, we already had a multidisciplinary clinic out there. So we said we can try to convert some of these virtual visits into multidisciplinary clinic visits. And I'm only bringing this again because when we look into the future, and we look at the possibility of virtual care becoming a part of the way we deliver care, multidisciplinary virtual care is going to be a lot more easier to put into play rather than trying to have different clinicians show up in clinic at the same time and get them together. So if you look at clinic, inpatient and outpatient visits in the future, they will be virtual, and a lot of them will actually also be multidisciplinary, so you can talk to all the clinicians at the same point in time. And we were doing that with our heart failure patients. You can see our nurse practitioner out there, my heart failure colleague, and the patient, and we would share the device diagnostics from the devices with the patients and show them what their parameters look like and see if we could help them change their practice mode. Now, just a few more minutes on heart failure. I think we all recognize it's one of the biggest scourge or one of the biggest problems for causing repeated hospitalizations, and the drain on the national exchequer is almost as much as $70 billion. And it doesn't spare any part of the country. Every nook and cranny has patients with heart failure out there. And we also know that with every readmission, patients actually decline in their clinical condition and they never come back to normal. There's a gradual decline until they develop pump failure. But now we have these devices that are implanted in them that have the ability to capture this information through sensors and actually treat them 30 days before they actually develop heart failure to prevent readmission. So the opportunity of predicting and preventing heart failure now is a real possibility. So this is a slide, actually, I'm going to go back. I must have hit it too fast. This is a slide I think I first showed it at a clinical conference in 2008, and I'm still showing it right now. And the reason I'm showing it is because now we're 80% almost there where we need to be. And this slide basically shows that, there are patients with heart failure before they actually develop heart failure hospitalization, like Paul did. There are a number of comorbid conditions they have, there are a number of triggers they have, and those comorbid conditions can be diabetes, hypertension, renal disease that we just talked about, as well as COPD and atrial fibrillation, all of which actually Paul had. There are now sensors for each one of those disease states, right? We looked at the continuous glucose monitoring as an external sensor for patients with diabetes. We have hypertension strategies now to monitor patients from afar. So there are sensors for both triggers, for electrolytes, ischemia, as well as arrhythmias. And we also have watches now that can measure a slew of variables, many of them getting validated. We have continuous BNP monitoring strategies that are being validated as we speak. You can only imagine that the change in the way we look after patients with heart failure will dramatically change, where patients can actually monitor their BNP and adjust their doses based off that. Again, these are potentially being validated at this point in time. And then there are obviously sophisticated sensors and then device data that we already talked about. If we could just find a mechanism of putting this data together in an individual patient with the triggers, with the comorbid conditions, what their baseline neurohormonal status was, along with these implantable as well as wearable sensors, you can only imagine that the potential for refining our risk strategies is immense. Biggest issue out here is the data. Are we going to do this? Some of it is already all integrated inside the devices that I already told you, that there are integrated sensor measures that allow us to do this. And that's the biggest conundrum, is how are we going to manage the data? And this is where we really have to use AI to help us collect, help us curate, help us annotate, help us analyze, and use that data to eventually predict and prevent disease. Now, there's a fair amount of visible data that we are all well aware of that we can see that is in our EMRs, but there's this whole slew of invisible data that is the social, cultural, environmental data that we know actually predicts 80% of disease that we're not still able to include in our EMRs. But those are health data platforms that are being developed. And we know that there's this whole move towards in the future also have all the omics, whether it's proteomics, genomics, and folks are doing work on that. That's a while away, but that's where the concept that was raised during one of the presentations this morning about multimodal data is going to be really important, where different sources, different forms of data, whether they're text, they're tables, they're voice data, there's speech data, there's videos and images, all of that really needs to find its way, and converting the dark into the visible And there are already strategies that are actually happening to make that happen. Now, this is a little bit, when we talk about AI, I'm trying to oversimplify it. When we say it could be analytic AI, it could be, generative AI, it could be multimodal AI. But just from the analytic AI perspective, I think all of us recognize that machine eyes or deep learning algorithms that look at different imagery, for example, so machine eyes can look into the human eyes, look at retinal photographs, and actually predict which patients have chronic kidney disease or are going to develop chronic kidney disease. They can look at the eye and tell you what your hemoglobin A1C level at that point in time is. They can look inside the eyes and actually tell you what your atherosclerotic disease features are and what your blood pressure actually is. That's all published also. And there you can look in the eyes and also predict which patients are going to develop Alzheimer's. Now, these are things that the machine can see that the human eyes cannot. And then obviously there are other algorithms that can work off. This is one of the algorithms at MGH that looks at, low-dose CT evaluation of pulmonary nodules and actually predict which patients are going to develop cancer 6 years, which may be called benign at that point in time, but can actually predict which patients are going to develop cancer in 6 years from now. So there's a fair amount within the spectrum of imaging and machine eyes that we already talked about this morning, but I think is going to be really important. And the important thing out here is that, diabetes, hypertension, chronic kidney disease, all of the things, Paul actually had those, and there are strategies that will allow us to actually predict and hopefully prevent those. Now, what about atrial fibrillation? Now, so atrial fibrillation, it can, as I said, when it occurs alongside with heart failure, it is responsible. It's something we call as a double whammy, right? And anyone above the age of 45 out here, there's a 1 in 3 chance that you will develop atrial fibrillation over the course of your lifetime. And I think it's important that for us to recognize that the AI ECG now, that is artificial intelligence strategies or just machine eyes looking at the ECG, can now tell you what your left atrial pressure is, tell you what the pulmonary capillary wedge pressure is, can even tell you whether you have structural heart disease, but can also predict if you're going to develop atrial fibrillation or develop stroke in the near future. So this is just to show you that we can look at machine learning approaches, looking at databases from the EMRs to actually risk stratify which patients are at higher risk for developing stroke. But beyond that, you can incorporate the AI ECG strategies to actually further enhance that risk stratification to really predict which patients are going to develop stroke and then decide whether you need to intervene early or not. Now, this is some work we've done where we looked at patch monitors, and looking at the patch monitors, the first 24 hours of patch monitors, we could actually identify which patients were going to develop atrial fibrillation over the next 13 days. So it gives you an insight as to how we are going to change our risk stratification approaches and how we can modulate and modify disease in these patients. And then obviously this is work that Emo has helped us with it, doing the Watch QT, actually led the Watch QT effort. This is obviously was presented with a French group initially when we did it. This was done during the COVID period where we used watches to monitor patients who were getting hydroxychloroquine in France to measure the QT interval to see if they were at any risk of developing proarrhythmias. We replicated the same stuff at MGH. But just to give you an idea that there are machine learning approaches, there are sensor-based approaches, and there are cloud-based algorithms now that can help us monitor many of these patients with atrial fibrillation, even at home. Now, this is work from Steve Lubitz and Sean Khurshid, and really elegant work looking at a combination of looking at different risk stratification scores and looking at AI ECG to help predict which patients actually go on to develop atrial fibrillation. And the interesting thing out here is that they could predict with a fair amount of assurance that patients were developing atrial fibrillation within a 5-year period. But importantly, you can see that this was developed a common algorithm, was then studied at MGH in the Brigham, and found that the algorithm actually behaved quite differently within the two institutions. And these two institutions are just about 5 miles in distance. Now, why is that the case. And I think it's important out here really bring into consideration the generalizability of the data, the equity and the implications of these two things. And let me give you an example. So at Mass General Hospital, 5% of our patient discharges are Black patients. You move 5 miles away, and about 15% are Black patient discharges from the Brigham. And you go 8 miles further down, Boston Medical Center, about 40% of our patients are Black. You can only imagine that algorithms that are developed from a data set in one hospital may not necessarily work in the data sets in the other hospital. And that's because we know that the social and income inequality have biological consequences, and these can have different representation within the machine eye algorithms that are picking up inferences. And I think it's so important for us to recognize that the generalizability of the data sets is as important. Now, I usually like to show this picture only because when I landed at Oxford to do my PhD, I was handed this tape, a Holter monitor of a patient who actually died with the Holter monitor on after 8 hours of recording. And as a part of my PhD, I was told, go figure it out, what actually happened out here. So I spent 16 hours a day for 16 weeks, measuring every little interval out there, trying to come up with a hypothesis, looking at QT interval variability, respiratory rate, RR intervariability, and all the other autonomic measures out there. And it generated a nice paper after 6 months of laborious task on one patient. But now this is work we presented last year at HRS as a late breaker. We are able to actually determine with an AUC score of 0.94, which patients are going to develop VT or VF after looking at the first 24 hours of their patch monitor within the next 13 days, who are going to develop VT or VF. And then there's work actually now, which was recently published in Circulation, that actually has looked at machine learning strategies using electronic medical record data to predict which patients might have an out-of-hospital cardiac arrest. So there's a moving target out here in how we can actually risk stratify patients. And the reason I'm showing this ventricular tachycardia is because Paul had atrial fibrillation and Paul also had ventricular tachycardia. Now, Paul also got a resynchronization therapy device. And there's been a fair amount of machine learning strategies into resynchronization devices. And there have been ways of trying to really phenogroup the patients a little more elegantly and try to figure out why some patients do well and some patients don't do well. And interestingly enough, and this is work from Mayo Clinic, it doesn't work well. Machine learning doesn't work well when we're trying to predict atrial fibrillation readmissions, heart failure readmissions, as well as CRT response. And why is that? And a part of the problem is, one is our own understanding of the biological and physiological signals is incomplete, but more importantly, the data related to where the lead is located, where the scar distribution is, what the interaction with the excitation wavefront is, none of that is in the medical records for people to glean to actually be able to come up with reliable predictive models. And I think that's where the whole multimodality theme of trying to use sources of data from different modes, both image, videos, as well as clinical data, will make the difference in actually enhancing our ability to predict which patients do well or not. Now, Paul had atrial fibrillation, and fortunately, you did not have to ablate him. But this is just to show you that there are lots of real-time changes happening in the way we treat atrial fibrillation. So this is an ablation that I'm doing using augmented reality with the Senti AR system, where I'm actually able to holographically pull in the three-dimensional cardio image and clip it with my movements of the VR glasses that I'm wearing at the same time. It's going to change the way we perform the procedure. It's going to change the way the job description of the people who help us during the procedure is going to change too. And interestingly enough, at the same time, there are computer simulation strategies now that you can look at a 12 lead and you can determine where that arrhythmia is coming from. Before you actually even go in to do the procedure, it can target where the arrhythmia is coming from, make the procedure considerably, again, a lot more easier out here. So that's about atrial fibrillation that Paul had and ventricular tachycardia. He also had hypertension, and we know that there's a fair amount of machine learning data. There's a fair amount of wearable data now showing that continuous blood pressure monitoring may actually be more important than isolated, periodic, once a week or once a month measurements that we make conventionally. And that using that information, you can decide which patients require intensive treatment versus those that do not require intensive treatment. And that we need to really individualize our treatment strategies rather than trying to use that one size fit all strategy like we've been doing. So what about Paul? What happened to Paul? So Paul actually did all right. His ejection fraction from 45% went up to 70%. So now from a patient who had severe heart failure, he had no more heart failure at the age of 75. An anonymous neighbor actually donated her kidney to Paul. So Paul now at the age of 76 had no renal failure, had no heart failure, and he became a dancing instructor at the senior center. He met his wife at the senior center, got married to her, and then moved on to Florida to start an antique business. This is Paul at the age of 90, 20 years after he'd been told that he had 1 month to live, but turned out to do all right. So what went wrong out here? I think what went wrong was that chronic diseases were allowed to progress to renal and heart failure. And all of it was actually preventable. And a part of that problem is also the way we actually delivered care at that point in time. We continue to do it right now. And that's the thesis that I'm trying to make is care was episodic, was transactional, was siloed. And then beyond that, you can only imagine when I talked about that medicine is more about finding a tenable life with your disease, Paul lost several years of his life, of his youth. And the hospital system obviously had to incur the expenses with repeated hemodialysis and heart failure admissions. And I think it's really important that we recognize that there are a lot of things that can be preventable, and it is upon us to be larger than our specialties and learn to look at patients more holistically and try to figure out what's actually going out there to prevent disease, than rather than just to treat the episodic occurrence that me and Dr. Oral were actually talking about this morning. So I think it's important to really understand that we have to make the healthcare system more sustainable. We have to be able to fulfill this demand for value. But the only way to do it is by becoming more digital. But it's also important for us to recognize that being digital is very different from being digitized. Being digital is a change in the value proposition. It is the change in the culture. It is a change in the way we practice medicine. Just having digitized records doesn't make us digital at all. I think we need to redefine the value proposition by really understanding that we have to move from what is transactional care, where we see our patients on a 6-monthly, 12-monthly, 2-yearly basis. Patients don't fall ill on a 6-monthly, 12-monthly, 2-yearly basis. They can fall ill anytime. We have to have that modus where we can actually move from what is something that is transactional to something that's continuous. And we know that there are already examples of that, like implanted devices, where we continuously monitor our patients. And much of this monitoring also is reinforced with AI-driven logic. And I think we as electrophysiologists already practice something that is called exception-based care. We used to see our patients with implanted devices every month, then every 3 months. Now we see them every year or every 2 years, because we know that we can follow them from a distance and see them only when they actually need to see us. And then the whole concept of this digital strategies will evolve into the MYOD, is manage your own disease. We need to create the right construct for patients to have more skin in the game so that they can be more responsible for themselves. Otherwise, healthcare is essentially going to be non-sustainable the way we practice it at this point in time. Now, remote monitoring is a big deal. And I know almost every center is actually trying to develop remote monitoring strategies, not just for those with implanted devices or those with wearables, for really disease states as well as for home-based care out here. And the only way to do that is going to be the synergistic convergence that we talked about of conventional AI with generative AI. And I'll talk about that very briefly, which is the only way we can actually provide chronic care, prevents readmissions and enhance self-management of patients. And there are already spectrums of home-based care that I think all institutions are already engaged in. whether they're urgent care, whether there's home hospital, or whether it's home-based care, or whether it's home care that's palliative or palliative service. These are already happening. They're not all scalable the way they're being practiced. It is only through the injection of this digital culture of having sensor-aided approaches that they can become scalable and actually make healthcare a lot more sustainable. Now, I know no talk would be complete without talking about generative AI. I'm not going to show you any significant data on that, but I think we all recognize, ChatGPT and all the large language models, that they help us decode data sets. They are going to change the way we practice medicine for sure. We're already using ambient notes now experimentally, where you walk into the clinic room and your note is being produced. Barely needs to be edited at this point in time, but there are ambient notes. The whole concept of liberating ourselves from the keyboard and unchaining ourselves from, the mundane back office's tasks of, prescription writing and pre-authorizations is all going to be taken over by generative AI. And that's the only way forward, because that might then allow us to spend more time with our patients and get to know them. And we also know that generative AI is also being used to predict hospitalizations, right? ChatGPT was recently used to predict hospitalization at NYU. Again, the accuracy score was not great. It was about 78%, better than the conventional physician score of 67% or so. But goes to show that generative AI is going to change some of the ways we're actually looking after patients with heart failure. But importantly, I think the heart failure readmissions, some of the work I'm doing now with the folks at MIT, is looking at event-based contrastive learning, which is looking at these multimodal strategies for looking at an event before and after and seeing if you can actually predict readmissions with that for both atrial fibrillation as well as for heart failure. And the hope is that eventually generative AI is probably the only way that allows us to talk to data like it was a human being, that will allow our patients to actually manage themselves using their own data in a much better fashion. So like all academic medical centers, I look at the practice of medicine in a triad. I think we all look at it that way, that there's an upstream specialty services and complicated surgical services that we provide. There's this whole midstream of chronic disease where we spend $3 of our $4 are spent in that chronic disease care, like Paul. And then we have mainstream, that is wellness. And the reason I bring this up is because already I think all of our centers are seeing a lot of changes where internists are leaving practices and wellnesses they're becoming third-party vendor strategies that are taking over our wellness approach. And you can only imagine that the same thing will happen even in the midstream approach for chronic disease. You can only imagine that patients who have heart failure, it is impossible for a group of 10 heart failure clinicians who follow 7,000 patients to look after the trajectory of each of those patients on a daily basis and predict which ones are going to be brittle. It's just impossible to do that. And that's where I think third-party vendors are going to come into play. And that's where I think as academic medical centers, we're going to find that our mainstream care and our midstream care is going to get disrupted. And we're going to have to rely primarily on specialty care. And we need to start fixing that. We need to start innovating and experimenting to make sure that we're ready for that stage when we find different ways of care actually eroding into our upstream care. Because you can imagine that with enhanced wellness and with enhanced midstream approaches, again, not immediately, but coming down the pike, the need for specialty care also is going to diminish over time. This is something, again, I'm not going to belabor. I think we touched upon this morning, and I've been trying to think about this talk for this concept of disappearing disciplines for a while. With changing technology and changing demographics and the different disease mixes that we're seeing evolving as we treat them, we're going to see a lot of changes in how we practice clinical medicine. We're going to see a lot of changes in the need for general cardiology, and the need for subspecialty is going to change in ways that are predictable, but we're not paying attention to. And then obviously you can already see that potential clinical workforce, and this is from Accenture, showing that at least 30 to 40% of the different job descriptions we're looking at patients with are going to change among the clinical workforce in the coming 5 to 6 years. we've talked a lot already about future models of care, and I'm not going to belabor this, but I think the only way to kind of make this sustainable in some way is through shared saving strategies, value-based approaches that we're trying. And I think streaming services, I mean, this is almost akin to Netflix and streaming services. You see and you take what you like from different streaming services. I think part of that will also happen to medicine, where you will have different disease management models that will be taken care of by different streaming services who will help manage those patients. And then with a shared savings approach, work with hospital systems. So it's something that I think we need to be, again, paying attention to. Self-management approaches are probably the only way to make healthcare sustainable. And I think having patients have more skin in the game is going to be quite important. So I'm going to conclude by stating, we can talk about virtual care, sensors, and artificial intelligence, but there's a lovely saying by Francis Peabody who said that the secret of the care of the patient lies in caring for the patient. And I think care must always be personal, technology forever tamed, and we should continually strive to preserve the human touch. Thank you very much. Of course, Tony.
Yeah, thanks so much. Wonderful to see you. Phenomenal talk as always, and it's wonderful to hear such a clear vision of the positive possibilities for the future. Obviously, people also talk about the dark side of
course
technologies. I had two questions. One is, the enormous advances AI recently have largely been driven by data available. I mean, Anthropic, OpenAI are enormous consumers of data. And that is in direct tension with our concerns about privacy in the health profession. And that has limited our ability to develop similar models. So curious your thoughts about how we balance those things. The second relates to kind of your last points about the saving model and getting patients to have skin in the game. I mean, as you're no doubt aware, 23andMe was partly founded with the idea that by empowering patients with their genetic data, they would take more responsibility. They tried to move to a subscription model. They've largely failed, and the net worth of 23andMe is now zero. So where do we see these economic models going, particularly in an era where today's New England Journal of Medicine has two incredibly exciting papers about genome editing to cure sickle cell and thalassemia, but at a price tag of millions of dollars per patient? So how do we balance those things, the data and the money?
Yeah, I know. I'll start with your 23andMe thing. I think it's when we are trying to do something or make some changes, I think trying to approach it with generalities like 23andMe and saying, okay, you have your data, you can kind of now take responsibility. I think you have to choose the right use cases for self-management approaches to make a difference. And choosing those right self-use cases is incumbent upon us to find those and get people. For example, let's use the case of, for example, diabetes, type 2 diabetes. The use of continuous glucose monitoring has transformed the way people are now looking after themselves. So that's a success story out there. And now we also have, continuous glucose monitoring with AI-based algorithms that can individualize the insulin delivery in patients who are brittle insulin diabetics. I think this is going to have to be directed by us, not just that you have a cool technology and you say, I'm going to pass it on to you, and now you take responsibility. The messaging, the education, the feedback loop, and ensuring what the output you want from that is going to have to be a concerted effort, rather than having a cool toy to know what your genetic, predisposition is. And you really don't know for sure also that it never really got traction. So I think 23andMe, if it needs to really come back, they need to be able to pitch it in a more specific manner for disease states with educational tools around them to really make a difference. Again, so I think the AI-based approaches that we're talking about will need to be disease-specific initially. Then there will be an accompanying change in culture around it. And that will then transform the way we deliver care for most diseases over time. So again, I'm giving you the positive spin because you've given me the negative spin. I just want to at least have a balanced approach of how we look at some of these tools and technologies. In terms of data sets, I think that's the biggest problem. I think that's the linchpin. That's the chokehold of how fast we actually progress and move. Now, there are many centers. I work with a few companies that are looking at AI ECGs, for example, to develop algorithms for a variety of things we talked about. They're getting their data sets from 20 different IDTFs who actually have the data now, and obviously for a price. Now, is that the right way? Probably not. I think, open strategies are going to be important. There's some federated approaches also, as you know, are where they don't share the data, they share the algorithm, and you tweak the algorithm between different centers based on your own data set. So that way you're maintaining privacy of your data set. So I think, I don't have the answer to that. I think it requires a fair amount of regulatory oversight. I think the more we try to make things accessible and equitable, the greater risk at the same time we are of privacy and security issues. And I think we need to be paying attention to those at the same time. Yes.
Fantastic talk as usual. Whenever you talk, I have these emotions. I'm like excited when you start and get scared and disheartened by the time you're done. I wanted to a couple of questions. I mean, there's fears about when you have so much data and it's coming at you from every direction. You have all these people calling you. There's a fear that you end up just looking at the data and you forget that there's a human connection. So, what do you think about technology, how it affects us in our interactions with each other? How do we stay human still, and how do we preserve the doctor-patient relationship as we just get more and more and more data, and we de-emphasize that relationship? So that was my first question, and then the second question was on the value capture part that you kind of touched on a little bit. Lots of the value-based care models that you mentioned, they rely on the fact that you kind of do an intervention, for example, prevention of hypertension, renal disease, and then that results in prevention of disease, subsequent savings. But in the US, because there's so many different payers, there's so much disenrollment from that many of the payers can't capture that value that they're creating. So it's over time, they're not seeing the benefits. They're moving away from that value-based care model. So do you see that kind of continuing in absence of a one central system of care?
Yeah, so let me deal with your second question first, and then you can bring back the first question, which I kind of forgot. So I think that's if you look at the value-based care plans over the last couple of years, there's been an uptick on that. I think it's now about 35% of the plans are going in the value-based care. So people recognize that it's the only way to kind of move forward eventually. It's just the uptick has been so damn slow. We've been talking about it for 15 years, and it's really the uptick has been slow. And I think a part of that is there are larger centers like Geisinger and Kaiser that have their own health plans and have subsets of patients that they look after for lifetimes, that they're able to experiment with them and actually pull out the value within some of the care models out there. So I think that's going to be eventually the strategy. I think there's always going to be an issue if your health plan is for a year, like we just talked about a few minutes ago. There's no incentive for the insurance company to really invest into the future of your healthcare, because what's in it for them? Because you're going to change your health plan with your employer or the moment you move a city, depending on the mobile population. So I think that's always going to be a limitation, and I think that is one of the disincentives for going down the value-based approaches. I think the same thing speaks for academic hospitals and large hospitals actually with health plans. I think it's upon us to experiment. It's upon us to actually learn and then disseminate that information as to what the best value-based strategy can be. Because if not for us, who else could do that? But I agree, there are lots of barriers. I mean, this is not a simple solution. Other people would have fixed it. What I'm saying today is not something new. It's probably you're hearing it from a different angle, but it's been said before. People are struggling with it, but they're realizing that it is the way forward, and there is a gradual accrual in that direction. the humanistic component out there. I think that's really, incumbent again upon us as clinicians and as teachers to make sure that the next generation of clinicians is not completely data obsessed, which actually, even from my generation to the next generation, there's a huge change in how, I would say the younger residents and fellows will only look at the data on the monitor and oftentimes not look at the patient. And you can glean a lot of the information by looking at the patient without looking at the data. And I think that's something that needs to be touched upon and preserved, and it needs to be a part of the curriculum. And I don't think there's any curriculum that is necessarily teaching you web-based manners to, kind of not bedside manners to kind of manage your patients over virtual care strategies or even, how do you incorporate AI? I think the main thing is that we're going to have to look at AI as an assistive tool, not as a replacement strategy. And I think for that, our clinical skill sets for the coming many coming years will always need to be preserved. But I can say that in 15 to 20 years from now, that's what you're leaning towards. There will be an erosion of clinical skill sets. There are skill sets that if you don't use necessarily, you kind of lose them along the way. And some of those are based off empathy and humanistic approaches. And I think we have to pay a conscious effort to it to ensure that we preserve it. And I'm worried about it too, but not so immediately. Yes.
Thank you. So I found it very interesting. That was something that I was thinking about while you were talking, is that one of the things that we do in medicine as providers is affect behavior. And that's always been a struggle. And I've seen a lot of technologies, if I take weight loss as an example, where we had a lot of technology that went into weight loss for a long time. We had a software that went into it, hardware products, physical buildings, Weight Watchers. And it didn't really move the needle that much on people changing their behavior, because you pretty much know if you eat more than you burn, you gain weight. If you gain weight, it's not good for you. And so people are empowered with the data and the information, but it was a real struggle to get people to move towards where they should go, because their own motivation moment. And ultimately injections came by and disrupted that industry, but it replaced the affection of the behavior, right? Affecting the behavior. So for a lot of the things that you're talking about, where people, and I'll give one more thing, it's, if you're going to have colon cancer, let's say you predict someone's going to have colon cancer, and you know that eating ultra processed foods is going to increase your risk of colon cancer, both things which we know now. The rate of people eating ultra processed foods hasn't changed that much. So how can we use these assistive technologies to help influence or impact that? Have you seen data around that? Is there movement in that direction?
Yeah, no, I think you make a really good point. I think you have to incentivize the behavior you want. Just like in clinical practice, I mean, we want to generate money, we incentivize RVUs, and that incentivize competition, and you get a culture that you did not necessarily set out to incentivize. You incentivize synergy, and you get a completely different team building strategies. I think the same thing with patient care also. I think there are incentive strategies that, for example, health plans already have, right? They give you a free watch and they measure your number of footsteps. And if you reach a certain target goal for over a month or 3 consecutive months, your premium for the next month is actually reduced. So there are incentives that can be worked for certain conditions and situations, but you also have to remember that when we say it doesn't work at all, is probably not true. I think it doesn't work for a large number of people, but it works for a number of people. So I think there will be incentives that need to be individualized. And that doesn't mean we don't incentivize behavior. We don't give people the education and the opportunity to control and modify their behavior. There are different kinds of, we were talking about this, there are companies, called Nudge, for example, that, it's a lifestyle company that nudges you constantly about your blood pressure, your weight, your exercise. I don't know how effective it is, but that's the goal out there. So I think incentives are important. They need to be, however, individualized. There's never going to be a one-size-fits-all strategy. And if you have a simple pill or injection that is going to solve the problem, rather than you modifying your behavior and avoiding all the things you love, it's going to obviously win. So I think that's something we have to recognize. Human behavior is always going to be a challenge, but we also have to recognize that it's never going to be a one size fit all. Thank you. Yep, go ahead.
Oh, thank you. Good to talk. Quick question. So right now, experts look at sort of the low-level sensor data with physiologic variables or whatever. In the future, we talk about putting AI or even just algorithms that take multiple sensors worth of data and kind of provide some sort of high-level output or some supportive decision or alert or wherever it happens to be. At some point, the physicians, I guess the question about liability now, how is that going to be managed in the future? I mean, is the health system going to accept the liability for the decisions or the alerts that are missed by algorithms? Like most of which are not 100% effective. They're going to miss some stuff, right? But obviously, experts miss stuff too, but they're humans, and that's more expected, I suppose. Can you talk a little bit about your thoughts on the liability?
Yeah, no, it's a good point. It's one that we've been struggling with for a while. For example, remote monitoring in cardiac electrophysiology is something that we've been doing since 2006, seven or so. And it's still not done in Europe for exactly the same reasons, the legality and the ethics and, ownership and not being responsible for patients on weekends. I think that's going to have to change. You don't fall ill only on weekdays, right? So I think that behavior change is going to occur. We're already in the US. We look after our patients on the weekends all the time anyway, and we get alerts, and we're responsible for alerts, and we have backup teams to take those alerts. So there are issues with it. Now the question, I mean, those are obviously alerts related to, device therapy. So there will be a categorizing strategy of what alerts are categorized as low, intermediate, high degree alerts. And based off that, I think folks will have a filtered approach of who to alert and how to alert. Yes, there will be some regulatory issues around it. I do think, this is my personal opinion, that medicine is going to become a 7-day work job. As much as we try to keep it, 5 days and deal with emergencies on the weekends, that is going to dissipate over time. Work will percolate, and remote monitoring strategies will be a part of that approach. Right. Thank you. All right. Well, thank you all. Appreciate it.